in the field of rural health and rural mental health, and some with specific expertise in autism and some not, in other health areas. But we wanted to pick their brains. Too loud, or we wanted to. So can you hear me now? No, it's not. It's not working because it's feeding back to me. Okay, so we have invited experts here, stakeholders from rural communities, and also people who are doing research in the area of rural health and community mental health. Some with expertise in autism, some not. But hoping to pick their brains about what might be some of the barriers and strengths of rural communities and things that we may need to think about in overcoming some of those barriers to improve the access to autism evidence-based services in the area. So I'd like to introduce Jordan Albright, who's going to be our moderator today for this panel. We do plan to end the panel by 1:30, so we're going to go ahead and get started, but please feel free to eat your lunch as you go, and if you need to walk out to go to the bathroom, you're welcome to come and go as needed. Jordan is going to moderate the panel and keep us moving along. So thank you, Jordan. And if you have any questions, please feel free to come in. All right, so to get started, I'm just going to ask each of the panelists to introduce themselves. Just give a brief summary of your name and where you're coming from, and hopefully the microphone works, but if not, let us know, and we will just talk with our loudest voices. All right, would you like to start us off?
Yes, is it working? Yes. All right. Hello, my name is Angie Leonard, and I am from Roanoke, Virginia, just right up the road about an hour, and I am the CEO of an organization called Take Business Run Services, and we run programs for children with autism through our specialized day school called the Blue Ridge Autism and Achievement Center. We also run adult programs, employment services, in-home services, and a community day program. Community engagement, community coaching for adults with disabilities, various disabilities, not just autism. And we have 4 locations, Lynchburg, Lexington, and 2 in Roanoke. And I have a son. His name is Joshua. He's 23 years old. He has some intellectual disabilities and is also on the autism spectrum. And he is employed at 2 different places in Roanoke, and is a very active young man in Special Olympics and social media and all kinds of things that we try to keep at bay sometimes. Thank you very much.
Hi, I'm Amy Drahota. I'm an assistant professor at the Michigan State University. I am a clinical psychologist. I'm in the Department of Psychology at MSU, both in clinical psychology and the community psychology program. My research is focused on services research for individuals with autism, but also I am particularly interested in the research behind dissemination strategies, so basically how to spread knowledge to different stakeholders, as well as implementation strategies, evidence-based strategies that will help agencies adopt evidence-based practices, implement, and hopefully with ability, and then and also sustain the use of evidence-based practices for individuals with autism. And so I'm really glad to be here.
Thank you for having me here. And my work is very similar to Amy's work. My name is Lisa Rudolph. I'm from the University of Kentucky, and I did try to stay up to midnight last night. I just turned off the TV anyway. My work, has been largely influenced. I have a 50-year-old sister with autism and intellectual disability, and over time became more and more interested in, even, when you grow up with a sibling, you see the lack of services. And so the work I've been doing most recently involves trying to improve our public school services outcomes. And so we have a consultation intervention called Compass, where we go in and we work with parents and teachers to together in a collaborative fashion to identify the goals that children with autism need to learn, social communication, independent learning skills, and then the support that teachers need in the implementation of the teaching plan. So that's been the basis of our work. And now we've got a grant looking at teacher burnout, because we found that special education teachers who had higher burnout, those kids made less progress in our study. And then we're also have funding to train people in recovery. So far, it's just been me and one other person to demonstrate that we can actually train people and, again, give us that dissemination piece.
Hi, I'm Susanna Poe. I'm a professor at the WVU School of Medicine and Pediatrics at the Neurodevelopmental Center. I'm a clinician and spent 20 years being the primary clinician at WVU diagnosing autism. But in the last 10 years, well, I'm saying how old I am. In the last 10 years, or 9 years, I have branched off to start a intensive autism clinic that has a dual purpose of providing evidence-based services to young children with autism in a very underserved area. We've offered free services for 7 children, 7 to 9 children for the last 9 years while teaching WVU students, both graduate and undergraduate students, in how to provide evidence-based treatment to children. So, and we did that without funding, and so we're real pleased to say that this year we are being accepted by the hospital as a real center. We get our own floor of the hospital and we're building. So it's taken a long time in a very rural area, but we are starting to see the fruit of all that work. Also, I'm a CDC ambassador to West Virginia for Act Early, Learn with Signs, and helped a lot with getting autism insurance implemented in West Virginia. So my rural roots as a rural West Virginian go way back. I'm real happy to be here. Thank you.
Hi, I'm Amy Azano. I'm a researcher and rural education scholar here at Virginia Tech in the School of Education. I've been with VT-CAR, I think, since its beginning, and helped to start the SAFE program, supporting autism-friendly environments. I am the mother to a very smart and handsome young man who is on the autism spectrum, and I'm happy to be here. Thanks. Hello, I'm Dr. Teresa Tyson. I'm a family nurse practitioner with the Health Wagon. I don't know if any of y'all were fortunate to see the 60 Minutes. We actually was blessed to be on that. We're the only safety net clinic in far southwest Virginia. We have a very large geographic footprint. We have 2 stationary clinics and a mobile clinic that was started by Sister Vernon Kinney over 30 years ago. She was a Massachusetts Catholic nun that came to our region because of the significant healthcare disparities in the region. I guess I'm the one that does not have any experience with autism other than my sister and myself, who is also a nurse. We recently opened a group home, Eddie's Haven, and one of our individuals that we support there has autism. So just very blessed to be here. Thank you. My name is KJ Holbrook. I work for Mount Rogers Community Services Board. We serve the largest catchment area of any CSB in the state of Virginia. Includes West Glen, Smith County, Joel, Grayson, and the city of Gateway. Supervise a lot of the clinical services there. Some of the pertinent to this discussion are behavioral therapy services, therapeutic consultation. We also do community engagement and coaching, and we do run a youth crisis stabilization unit that is a residential unit where we are able to accept individuals diagnosed with IDD. And we are currently partnering with Dr. Sparkman of Virginia Tech on their focus groups for needs in rural areas, as well as our mobile autism clinic. Thank you. Good afternoon. I'm Diana Robbins. I'm a professor at the A.J. Drexel Autism Institute at Drexel University in Philadelphia, where I also lead the research program on early detection and intervention. And so I'm actually really excited to be part of this panel today because one of the things that I think will really move us forward is bringing together different disciplines and different perspectives so that we aren't stuck in our own one way of thinking about the world and thinking about how to make change. But if we put our heads together, I think we can really make a difference. So if you were here this morning, you've heard me talk about some of my work on screening. One of the main focuses of my career has been to try to develop and then refine strategies to help people in the community identify children with autism as early as possible. Because if you identify it earlier, you can start the targeted treatment that is the most helpful for helping these children learn skills and learn to engage with other people, which gives families the most positive outcomes. And so I'm very interested in trying to develop approaches to increase access to early detection and early treatment strategies for all children, not only those who are lucky enough to live right by a big university center or a big urban area where there's many, many providers to choose from.
Okay, Linda and Jay, I think it's now your turn to introduce yourself. You can unmute and talk. Hello? Please unmute. Your microphone is muted.
So we have some people joining us from Kansas, actually, the University of Kansas. Hopefully we will be able to get them to a point where they can introduce themselves and can contribute as well to the panel discussion.
Linda, Jay?
Yeah, well, hi, I'm Linda Heisenhouse. I'm a psychologist. Can you hear me?
So we're still on track. We're actually making really good time, so we'll do a couple more minutes of trying to figure out if we can get them to introduce themselves, and then we'll jump into the
Okay, thank you. Hello.
Hi, can you hear us now?
Yep, okay, thank you. Yep.
Can you hear us, Dennis?
Yes, very well, thank you. Please go ahead. Actually, it's your turn to introduce yourself.
All right, I am Dr. Tyson Powell, and I'm a board-certified behavior analyst at the doctorate level. For the last 20 years, I've been working on training and evidence-based practices. It started off with training service providers how to implement what is currently the RDT credential. What we found was that families were going through that training program because they wanted to have better skills when they were parenting their child with autism. So Jay and I applied for and got funding to develop the online and applied system for intervention skills, or otherwise known as OASIS, the OASIS Parent Training Program. And we were particularly interested in families in rural areas where they didn't have access to other services or consultants or direct service providers. And so we developed and tested OASIS using telehealth to have the parents learn some basic core competencies. And so the parents go online, they learn about information online, and then they come to clinic, and all of the coaching is delivered using distance-based technology. And what we found was that we can, in fact, using distance-based technology, coach parents on how to implement some of our basic behavioral strategies like contingent reinforcement, prompting, prompt baiting, shaping, etc. The other thing that we found with the training program is parents learned the language around behavior analysis and how to implement these skills with their children, is that they reported becoming better advocates for their kids as they sought services outside the home and in the school district. And so that's been kind of the focus of our work throughout the last, 15, 20 years and what brought us here today.
So, and my name is Jay Bazart, and I'm a associate research professor with Juniper Gardens Children's Project at University of Kansas. And so, like Linda said, I've worked with Linda on helping utilize technology to get services out to parents and children and the providers that need it so that they can have access to those evidence-based practices. In addition to OASIS, my work has also involved developing measures that can be scaled to providers who maybe typically don't use data to inform their practices, or even parents who may be providing treatment to their children in their home if they're in a rural or remote area and don't have access to services. So these measures are infant toddler measures. They're called IGDs, and they're being used in about 24 states now, and we've done randomized control trials to demonstrate that service providers who use these measures are better able to provide services, and we've seen improved outcomes in language growth for children whose service providers have used this, and it utilizes technology so that it's scalable and they can see their outcome scores immediately in the home or in the service provider centers. We're really excited to be involved in this because as easy as it seems to implement technology, we see the benefits of things like Facebook and Google, and those companies have billions of dollars, frankly, to make these scalable and usable to the people who access them. But obviously, us and anybody in that room don't have the resources to sometimes develop the tools that are needed to make them usable. But that's a really critical issue, and I think that's kind of an important theme of this conference is to identify what are those barriers, because we know there's barriers. We're obviously having trouble just connecting to this conference, and we have the technology to do that, but there's a lot of barriers that need to be addressed, and I think it's good to get our heads together and try to make those services available to those people who don't typically have access to them.
Great, thank you for introducing yourself.
Thanks for the invitation to be here.
You're welcome. So we're all really happy to keep doing that, and we will jump into the questions now. So feel free to chime in if you just want to raise your hand. If you have something to contribute, I will pass the microphone along. Same goes for you, Linda and Jay. Just kind of wave your hands in the air, and I'll bring the microphone over to the laptop. So our first question is, what are the major strengths and major barriers facing rural communities today with respect to access to ASD services? And we'd like to focus specifically on the unique strengths and barriers faced in regions of Appalachia. Who'd like to start us off?
When I think of strengths in autism services in my area, which is the 70% rural West Virginia, I would have to say that we have we have pockets of excellence. We have people in various roles in different parts of not everywhere, but in certain pockets where we just are providing the best services possible. And those people are passionate and make every effort to work together to move the whole state along. So that gives me a lot of hope to have a group of people who are dedicated and passionate about moving it forward. Challenges that we have is that 40% of our families live 2.5 hours from any medical professional, and so it's not possible to even make arrangements to get to diagnosis, much less not having to avoid a waiting list to do that. Up until the last week or 2 weeks ago in our state, Medicaid didn't fund any autism treatment services that were evidence-based or behaviorally based, nor did our birth to 3 system. So there's been a delay in getting services, evidence-based services accepted and offered to people across the state. So the biggest issue is funding. I think that we don't have systems in place that will provide services, will pay for services being provided to the children who need it. I have trained BTBAs for the last 10 years who, probably about 4 or 5 every year, that take the test and leave the state because they don't have any option for funding that makes sense to them, especially as a new practitioner. A lot of heads nodding. So my whole goal in starting my clinic was to train WVU students to stay in West Virginia, train them real well, and a lot of places are enjoying them right now. So I'd like to keep them in West Virginia. Those are my concerns for the strengths and the challenges in rural areas.
I think just as a healthcare provider, I see a lot of strengths like in our region, and I think we've got like such strong sense of family and community, and with for example, with our remote area medical event that we plan every year, and we did it for 19 years, we have unprecedented collaboration. I think it goes to the passion that you were talking about, that people are just so passionate. There's people that started out with us 19 years ago, and they're still at the table helping deliver care. And so I think that is the most thing that I'm most proud about is Appalachian culture is that, and then our people are just so, so resilient, and I see that even in my mom, we just come, in that area, there's just so much, of resiliency. But the weaknesses, I think, is certain, healthcare disparities. Our people in our region, in far southwest Virginia, they live 10 to 20 years less than their Eastern Shore counterparts. There's just such healthcare disparity. We're the belt for so many diseases, and I think that goes back to the Bible Belt and the issue, the strongness of the faith, because we're always praying about all these diseases that are in the Bible Belt. But, we're like, that we need all the prayers. I know that's what gets us by the clinic on a daily basis, but, it seems like we're facing so many obstacles. We're a medical professional shortage area, mental health professional shortage area, health professional shortage area. We have barriers, lack of transportation, and that's the reason that, Sister Bernie was so innovative all those years ago, was taking healthcare out into the community, so that, because often people do lack transportation, they can't make it to the clinic. We're a low resource area. In rural areas, there's just not a lot of resources, there's not a lot of infrastructure, and this, I think the social injustice that happens in the rural areas, as a whole is just very paramount as well.
Hi, everyone. So, taking a slightly different perspective, some of the work that I've done is evaluating for when agencies do exist, and these are for-profit, community-based agencies. When they do exist, there still exists variability in what the delivery of services are. So whether the services are thought to be evidence-based, they may not be delivered with much adherence to the training that those providers received, or it might be that a provider was trained by their supervisor, who was trained by their supervisor and their supervisor. So we do see these great deserts of services and the availability of services. And then when we get into studying when there is a service provider or agency there and what they're delivering, we see great variability in whether they're delivering something that we have evidence to use to meet the child's or adult's needs or not. Additionally, what I've heard from the CEOs or directors within these agencies is that in trying to meet the challenges of the families and the individuals who are coming in to seek services, there isn't a system for how to decide what new innovations or new treatments should be delivered with any system. So there's not really a systematic process for identifying needs for the whole agency or the whole community, especially if there seems to be an emergence of new needs. How do we evaluate that? How do we know that? And then how do we prepare? There's not really a system guiding agency directors to go down that path. So that does, of course, contribute to some of the disparities in both the availability of evidence-based practices, even when we see that there are available agencies around. Now, the good news is that, most of the directors and the providers I've talked with, they're doing the best they can. And so I think that's where these collaborations may be able to be very beneficial. Where someone like me, I don't know what boots on the ground really looks like in rural areas that are delivering services to individuals who watch them. But I have the time to be able to develop tools to help directors of these agencies maybe systematically roll out new things. And so I think the strength is in our collaboration, our common passion.
waving my hand.
I was just going to make a comment about rural schools and how that plays into some of these strengths and challenges. If you've ever seen Friday Night Lights, you know that rural schools play a very special role in rural communities. They tend to be the epicenter for sort of all things related to little kids. So especially if you have rural parents who maybe themselves have not had any sort of formal schooling beyond a high school degree, they might feel really intimidated going into a medical center if they have concerns about their child. So we know from the literature that kids in rural areas have later diagnosis, and often that's happening in these rural schools. So just to kind of add on to the other comments that have been made, rural schools we know are already under-resourced. So the schools a lot is being asked of the rural schools, and yet there's very little funding and resources that can help meet the needs of the parents and the children who are seeking a diagnosis. Also, when I say parents, a lot of the kids are living with grandparents and aunts and uncles. I've met a lot of kids in our related counties who are living with great-grandparents. So again, there's a generation gap, there's a knowledge gap, there's a digital gap. There are a lot of challenges that contribute to that. And then, you know, our governor right now is talking about trying to bring Virginia teacher pay up to a national standard because our teachers in Virginia get paid less. That's a great argument if you just look within Virginia and look at what rural teachers get paid compared to their suburban or urban counterparts, you'll find out what the real discrepancy is. So we're also asking our teacher prep service, our teacher prep program to help staff rural schools and paying them $20,000 less because we've sold people on this idea that rural communities are a great place to live and that it's cheaper to live there. And if you live in a rural community, you know that that's not true because you're driving those 2 or 3 hours to get to a hospital or to other resources. So just to kind of keep in mind the role that schools might play in the midst of these diagnoses and treatment for young children with autism.
Right, I think Linda wanted to contribute some additional thoughts to this question before we move on to our next one. So, I don't know how we can let her know.
Linda, are you ready? No,
Yes, I am ready. So, listening to what I could hear, can you hear me?
Yes, we can hear you.
Hello? Ooh, okay.
Yeah, hello. Yeah, we can hear you.
It sounds like, all right, it sounds like West Virginia faces some of the same struggles that we face here in Kansas, and particularly with regards to our rural and frontier areas here and lack of access to the services. One of the things that we have worked hard here in Kansas is to develop our telehealth capabilities, much like I also work in Alaska. And Alaska is a very rural and frontier state. They worked really hard to develop their telehealth capabilities. And a part of what we've done here, just for your guys' information, is pushed hard for mental health parity, because for delivering any kind of medical services using telehealth, there has to be the same benefit available for mental health, and autism treatment can fall underneath that. And so when you're looking at assessment or diagnostics or some of those early screenings, that definitely falls under that mental health parity law. So I think that would be something that you guys should keep in mind as you start to explore ways to be able to help get some of those early screening and diagnostics out to some of the rural communities. And the other thing that we've done is, like, you know, we've worked really hard in Kansas to get autism benefits covered, as with testifying and legislation, and under, and I'm sure you guys are all aware of this, under early periodic screening, diagnosis, and treatment, or in other words, EPSDT, autism treatment is required service under treatment from federally mandated guidelines for Medicaid programs. And so it's getting the systems put in place so that that becomes a reimbursable service. One of the things that we have in developing OASIS is that a way to try to circumvent the lack of service providers in our rural frontier areas was to train parents. And so, like I said, parents were going through our early provider training, and so we took that and we modified the language a little bit, but our parents go online, they learn the language of behavior analysis, and they use those practices during the coaching, which is all delivered via telehealth, in order to target a specific, like, language acquisition communication in their child, or increases in compliance or decreases in aberrant behaviors. And they come out the other side and they have these skills and they know how to target particular skills in their kids. So it should not, a concern that we're trying to put service providers out of a job. Well, that's not it at all. It's to augment it so parents can become an active advocate for their child and an active member of the treatment team as they work on those treatment goals. But it gives parents at least an avenue of understanding so that they are able to better parent their child while they're becoming advocates for their child in their local community, and that information can be delivered using distance-based technology. And we've done it at Polycom sites, we've done it at designated healthcare centers, and we've actually even connected families in our home with iPads. And so we've worked with some of the insurance companies out here that allow us to do that. Medicaid also will allow us to connect to the families in home, but that's advocacy. And so as you guys are starting to expand your health care coverage out there, I'm going to impart some words of wisdom from a battle-scarred warrior that also advocates for the use of distance-based technology as you're advocating for increased coverage. Because if you don't, then what's going to happen is you're going to say, oh, we now have autism benefits, but oh, wait, there's no way to get them out to these families, right? And so it has to, it's a how do you two-pronged approach. You're not only advocating for the service, but also for the means to be able to deliver this service in order to get reimbursed for it, because to build capacity, you have to get paid. The other thing that we did here in Kansas, as we started to, for the last 10.5 years, the state of Kansas paid me and my group at the K Center to deliver training around the state, to go out to these rural areas. And as families were identified and accessed services, and we held training programs, so we trained the service providers how to implement evidence-based practices and to follow a treatment plan, so that families then were able to access services, and we were able to start building capacity around the state to deliver this medically necessary treatment. And so another point of advocacy is, as you're pursuing the uptake of or the expansion of Medicaid services, that there's some responsibility to be able to ensure capacity to deliver those services. And if you could look to your legislators or your state leadership to identify some of those administrative Medicaid funds that could perhaps pay folks at the university to develop a training program such as what we have here in Kansas, to help you guys build capacity across your state.
Linda, that's actually a really nice transition into the next question, which is, what policy changes should we be recommending to our legislators based on some of the barriers and strengths that you've all mentioned so far?
So working with Matt Rogers, one of the things that we do is we're the lead for regional programming and a grant that was awarded to various regions across the state to increase crisis response and child psychiatry services. And so, obviously, Region 3 is very large. We couldn't really afford to pay a doctor to drive around all the CSBs to provide services, certainly not timely services. So we did create a pretty robust system with, in partnership with the University of Virginia, so that we have pretty much within 48 hours we can get a child in to see a psychiatrist for an evaluation if they're in process, which is pretty unheard of, especially in our area where most people wait several months. So then we started developing telehealth services internally, because from one side of our catchment area to the other can take about 3 hours just one way. So we developed some systems internally and found that they were very helpful. So then we participated in this federal grant called the eBackpack. Please don't ask me what that stands for. It's just called eBackpack. And the idea behind that was to use federal dollars to house telepsych units in 2 of our more remote schools in Bland County, so that they could not only receive mental health, but also physical evaluations and assessments and things like that. The problem we ran into, it was really great that we had legislators who threw money at it and said, here, yes, do this. And you have a list of services that you can bill under telehealth, which is great, but there is a tremendous amount of codes that are not billable for telehealth. So if the kid's sitting in the room with you, it's fine. You can see them, you can bill for it. If you do it by Polycom or some other avenue, then it's not. So we found that that was a tremendous barrier, and certainly feel like that's something we have worked with the Department of Medical Assistance Services to advocate for change in that area, and we have included in that ABA billing codes and things like that as well. But it certainly couldn't hurt to have a few more voices in that. And just being from far Southwest Virginia, the other issue is you can also throw money at Polycom and get Polycom units out there, but there are numerous places where the technology for that to be a secure connection and to actually be fast enough so that you don't look like you're in a frozen state of panic every other second, it just isn't there. And so that's been a pretty big barrier for us as well on many levels.
I really struggle with what the most important policy things are to start with. But it certainly seems like I've heard some comments from the panel about increasing the number of providers so that there are more people able to offer services. And I think that that's true probably everywhere, but it seems especially crucial in areas where people often have to travel many hours, and the likelihood of being able to do it for, say, one appointment to get a diagnosis is probably pretty high. But once you have the diagnosis, how can you possibly get the intensity that's recommended for treatment services if you have to spend half your day driving back and forth? And channeling my colleague, Dr. Giacomo Gavanti, who focuses on early intervention research, but also advocacy, he would say that it is a terrible lost opportunity if parents are basically told that they should stop working and stay home to either try to provide treatment for their own child, for which they're not trained, or maybe even worse, spend hours driving their child every day back and forth somewhere that's going to take 2 hours, 3 hours in each direction, because it takes away part of their own productivity and part of their own contributions to society. And it also puts a tremendous burden on parents that in addition to all of the kind of regular parenting stuff that we all have to do, you also now have to be your child's treatment provider. And although I think that it fills a gap, I think it would be a terrible misinterpretation to think that that's a solution rather than a temporary or a partial completion of the goal, instead of making sure that we get access to trained therapists, treatment providers who can offer the high fidelity, standardized treatments that we know are effective, instead of putting that burden right on the family and saying, well, you just live somewhere where we can't help you, so you're going to have to figure it out on your own. It
So I would love for some policy approaches to take that into account. Just to follow up with what Diana was saying, was the way that we've been thinking about this too, about the lack of capacity, is through intervention that's based on consultation. I mentioned that a little bit earlier when I was introducing myself. So the idea with consultation as an actual type of professional development in intervention and treatment is that maybe I'm working with 3 teachers who each have 3 or 4 students with autism. So I don't have to work with each one of those students, but I can share my knowledge and expertise in a collaborative fashion with this teacher who knows this child better than I do, and with the parent who knows the child better than everybody else in the team. And so we don't have ways to get reimbursement for that. I think it's the 90887 CPT code, you know, but that would be a way to really think differently about our services and what we define as intervention, is by having this kind of multi-tiered approach where you have the specialist who's been working with the actual treatment providers. So as the implementation practice, improving the intervention practice, what happens with the child who's, you know, after measuring.
Right, and I think that, so to give some context to the importance of dissemination and implementation science, so there's this figure that we talk about quite frequently, and this is across all of science, behavioral science, that it takes 17 years for 14% of original data to reach community use. So it takes 17 years for something that I might be studying right now to benefit anybody. And that's if I'm lucky and my studies are in that 14%. The other just sits on a pretty shelf somewhere. So, I do appreciate this conversation about training the trainers. It's a model that in research we're doing, but it sounds like it's not being utilized in community settings, in school settings, even though there's a lot of federal funding going into studying the effectiveness of train-the-trainer models. You know, it's devastating to think that it would be close to 20 years before that is utilized and reimbursable, because it really does come down to funding for our agency providers, right? So, you know, I place it within Maslow's hierarchy of needs. Like, for us as individuals, we need to make sure that we have food and shelter before we can do much else, be a part of a group and try to reach our goals. Similarly with agencies, you know, they have a hierarchy of needs. They need to keep their doors open and lights on. They need to then move on to, you know, having staff or clients, and then getting new clients. You know, it's this approach that's fairly systematic with some foundational things that have to be done. And so that's one of the reasons why I think bringing on new innovations can be challenging. If I'm trying to keep my doors open, I'm not going to think about train-the-trainer models. But it's unfortunate because the opportunity to leverage that is there if we can find some creative solution to reduce the burden.
And if you can't get paid for those services, you can't leave the doors open, and that's what we find in our area. I want to talk a little bit about conflicting demands, and for our population, and I would imagine it's pretty similar here in Virginia. West Virginia is the #1 opioid-affected state. Our foster care system has tripled with the number of kids who are put into the system because of opioid problems with their parents. So the reason I'm saying that is that we've lost attention for a lot of these kids. These kids don't have active, energetic, focused parents. Another concern that I have is, and I think this goes to what Diana was saying earlier this morning, my experience is educated, mobile, and financially secure people are the only ones who get care for their kids, because they're the ones who can find the services, can go to them. I have one mom who drives, for my clinic, drives her child an hour and a half each way, each day to come to our clinic because she can afford to do that. But I feel, and have felt for the 30 years I've been in this field, that every kid deserves that. And I think that's why we don't charge, that's why we take any kid that we can, because I have student power and I don't need it. No one's helped me bill yet, so we're good about that. That's changing. But I also think the key to these rural communities are schools and early intervention. These are people who are in the community, systems that are already in place in the community. My problem in getting into those, and we've offered to go and do training for those folks, is that they have always done it the way they've always done it. And it's really hard to break, see everybody nodding. You know, we would give you this training and these services, and we would give you follow-up through telehealth, and we would consult with you if you want it, but they don't want it, so.
So when we talk about legislators, I like to think about my son, and I just kind of resonate on what you just said about every child deserves to have the services and the education they need to leave school and be as independent as possible. And we know that varies between, individuals who are affected by autism. But I just have a question. How many people in this room are parents of a child with autism or a significant disability? How many people, of the ones that just raised your hands, how many of you feel like that your child is treated as a second-class citizen at times, maybe even a third-class citizen at times? So there's still people who feel that our kids aren't treated like the rest of us. And we had a nice dinner last night, and Dr. Ramey was very forthright as he was talking about some changes that have been made in our country in the past. We, I think, spoke specifically about Brown versus the Board of Education and how no one in this country, or any country, should be treated as a second-class citizen. And if we're going to make some changes legislatively, we need to have advocates, we need to have a plan, and we need to have advocacy that are willing to go to our legislators on a federal level and ask for changes and speak up for our kids. And so we need to get ourselves together, and we need to make that plan, and we can do it just like other people have done it. And sometimes, the biggest folks that make a difference are parents or teachers, or social workers. So I think it was mentioned also that right here in the state of Virginia, Warner is, well, I actually read it in the newspaper last night, that Warner is particularly interested in studying how we can make some changes in Appalachia and how we can minister to those families. And also agree with Teresa, man, they've got some grit and resilience, and they love their kids. We get the phone calls every week. It's a Blue Ridge Autism and Achievement Center, and they are willing to drive. And sometimes they don't have the transportation, and we're trying to figure all that out. And kudos to Virginia Tech for taking that van, I'm sure you'll hear about a little while, to them, and maybe trying to find some space where organizations can go in and provide services to people who can't make the 3-4 hour trip into Roanoke or Charlottesville or Richmond. But I think more than anything, for legislation reasons, I think it would be awesome if we could get a bunch of people together and make a plan, approach our legislators, and fight as hard as other people groups who have made such a big change.
Thank you all. And so emphasizing. Oh, okay.
Can you hear me?
Yes, go ahead.
Okay. I agree with that. I think with that, Angie was just talking.
Yes. I don't know if you can hear me, but yes, it was.
I agree with Angie. And one of the things that helped us here in Kansas was Autism Speaks, because they helped us draft our talking points for our legislators, and so they had a lobbyist that was on the inside that was down at the during all of our legislative sessions. So they kept us informed on when the particular subcommittee that was going to be overseeing services or access to services or the insurance mandates were going to speak, and then they were able to get us on the docket. And so if you can, so I would reach out to Autism Speaks as well, and they do have on their website a legislative advocacy package, I think, and then identify those key legislators that are going to help be willing to put the agenda forward, and having families is critical because families can definitely talk about the impact of kids and on their family life, right, on their ability to go out and have a family life. And so I think for us here in Kansas, that was definitely the way that we got traction, was to have a concentrated effort with key talking points across all of the groups that were going to testify and having to deliver judgment as well. That's it.
All right. I think Amy wanted to add one more additional point, so I'll pass that down.
I just wanted to add to what Susanna was saying about wanting to help rural schools, and I really do agree that I think rural schools are sort of an obvious answer. It's a place where we can make an immediate difference. But I don't know that teachers are disinterested, even when they have free professional development that might come to them. I just think they're so tapped. There's so many expectations on teachers in general, and especially on special ed teachers in rural areas. But the truth of the matter is that it's a lot of times the general education teachers that have children with autism in their classrooms, and they have very little training. Usually it's just one required course in their teacher prep program, and that's exceptional learners. And so that covers everything from a gifted learner to a child with an intellectual disability to autism. So maybe a week on each topic is my point. So we already know that the rural schools are, we already know that education is so inequitably funded because it's based on your tax revenue and your housing. And so I think when Dr. Ramey last night also mentioned this need for sweeping reform, and if we're going to talk about that, we have to address just the absolute inequities that rural schools are facing. So we can't ask more of them because it's just going to add something to their plate. Nothing comes off the plate. So I just think that's just a really, I didn't want that to get missed. And, a for example is if we compare our local Southwest school division, so in Tazewell County, for example, their per pupil expenditure is under $9,000. It's somewhere around $8,700. In Fairfax County, it's nearly $17,000 for a per pupil expenditure. So if you look at things like gifted education, there's usually a $30,000 to $35,000 budget for Southwest schools. That's pre-K through 12th grade. So that's your dual enrollment, your AP classes, your talent development, et cetera. And you're comparing that to, again, Fairfax County, they have a $2 million budget just for their pre-K talent development. So if that's not autism related, but it gives you a for instance. So when we talk about the inequities in funding, we can show you very easily what that looks like. So I think that going in and training teachers would be great, but sweeping reform would not be asking any more of those teachers. It's putting somebody in that school, recognizing that rural schools could be a community bridge. Those agencies that we're talking about, Medicaid, those places could be part of the school system or in tandem with or working alongside. And again, it would be it's a safe space for parents and grandparents to go to already get the resources. They know how to navigate schools. They don't know how to navigate all these other agencies. So there's a real solution somewhere in that, but it can't be asking more of the same people who are already doing so much more. You will not find more committed teachers than the ones who are working in these radically under-resourced rural schools and getting paid a lot less than their peers in other places. Yeah.
No, I appreciate that. And it led to a question I have related to integrated school systems or integrated school services, or by I can ask you either, or the health health-based school center models, any of those that are being utilized here, that you know of? The school-based health center, so those aren't being utilized, and those models aren't being utilized here. Okay, yeah, I mean, but in terms of potential policy shifts, if it seems very overwhelming to do broad-reaching changes, which I think, I agree, would be necessary and needed, but we know that there's some, at times, inaction by legislation across our history, but those might be models that could be at least explored and then funded, that wouldn't then create more service burden on educators. Yeah.
All right, so I'm going to take the mic over to Dr. Craig Rangy, who actually is helping with our rural outreach project in a lot of capacities. So,
I want to make just a specific comment about what might be done. Having worked with and for the broad developmental disabilities community almost all my life, I think that we have been divided and on occasion conquered, because we splinter off into groups, and please don't take this as anything derogatory about autism, but if autism competes on its own and is not in alliance with other disabilities, it has a smaller voice. And so this banding together that creates multiple, multifaceted constituencies that then could be affiliated directly with an institution that the communities already value, and there aren't that many. I do think that it's the school system, and I don't think, I'm in complete agreement, it is not asking the existing people with existing resources to do more. But when you think about co-location of services, schools are a wonderful place to deliver health care. We're trying to set up a model in Roanoke, Virginia, where the health care is delivered not just to the students, but to the entire family, because we understand the cascade of social determinants of health, and someone whose grandmother with whom they're living is suffering from depression or untreated diabetes or any number of other conditions, who has a direct influence on the child, ends up having a set of negative forces come into play that could be dealt with more effectively. Now, all school systems are not eager to take on more responsibilities, and schools of education have to change in their focus so that they become more multidisciplinary, more collaborative, more welcoming of additional services coming in. But trying to build systems from the ground up, trying to design the places where healthcare, the places where continuing education takes place, where job placement, skills, and other things are incorporated in an institution that the country, at least used to, have a strong commitment to, that is excellent public education. I think it's worth going down that road and having conversations here in Virginia with the governor, the Secretary of Education, with people in really key leadership positions at the top about how to build not only a more effective system, but a more efficient system. So I believe we can demonstrate that we can deliver better services at lower costs to the vulnerable section of the population. I'm not talking about coercing anyone to participate, but if you offer those great services, you center them in the schools, you're open not just on Friday night for the football games, which become a focal point for the community, but you're open for a much broader period each day. those kind of 21st century schools that become community centers, become healthcare delivery vehicles, I think could transform at a fraction of the cost the delivery of services to children who are highly vulnerable and very difficult to serve. Think about, we have the buses that are not being used except in the morning and the afternoon. We have bus drivers that we pay. Why can't they be helping to transport kids to certain treatment places? So it's a broad idea. It's not novel with me, but I think it certainly is a powerful idea. And it's not education. What other agency? Is it health? Is it the church? I mean, what are the few institutions that are supposed to have contact with every member of the population at certain points in their lifespan? It's a small list, I think.
All right, I want to thank all of our panel members for sharing all of their insightful opinions and thoughts on the matter. We have a couple of minutes left to open the floor for anyone in the audience who would like to ask questions or make any comments on the topic. Does anyone have any questions?
Thank you. I love that this began talking about strengths and a number surfaced readily. And I appreciate the comment that sometimes it seems like people aren't receptive to new ways of doing things. I think all of us have been stuck in our own ways as well as people we work with. I will tell you a success story, and this is about early child care, not focused only on children with special needs, but they are included. And we had several projects, and we worked mostly in rural Mississippi, but also Alabama and Louisiana. And we worked with providers who had less than a high school education, often home-based care, and the care they were providing was woefully in opposition to evidence-based, to be honest. And what we did was send in people. Now, this is intensive and expensive. It's not the solution, but I'm talking about changing attitudes and opening minds and building partnerships. We found that individuals, when they saw firsthand that different behavioral practices resulted in immediate and lasting change in children, we found people who thought some children were boring, bad, or evil, and that's just a bad human being. They were doing punitive things, and they saw somebody say, oh, he's the brightest child here. We just thought he was like a bad seed. And once they saw transformation in the child, they became not only advocates, but they became highly skilled, and they maintained that up to 2 years later. So I think we have to be sure that some of the negative experiences we've had don't keep us from finding new ways, just like years ago, when we had a child who didn't get better. It's not the child's fault. We just haven't found the right method. I'd say the same for the administrators and the frontline direct care providers. We've witnessed absolutely 180-degree changes in individuals, but it wasn't yakking at them, telling them, or even the videos, which I think this morning were very powerful. But hands-on in their setting with children they know might really help generate the hope that all children can thrive and are contributing. They already are, but not everyone recognizes it.
All right, so I believe we are close to our time. 4 minutes? All right, so we have 4 more minutes for any additional questions or comments from the crowd. Does anyone else have anything you'd like to ask our panel or additional commentary? All right.
speak to the last comment as a parent, and I am actually a teacher educator, but as a parent of two sons with autism, I found that, and as a special ed teacher, so I've worn many hats, but I found that in raising my son, sometimes gaining their teachers and case managers' belief in them was really difficult. And I didn't have time to wait for their teachers to be astonished over their brightness. And so I found in some cases that lack of commitment to them actually became a barrier to their success. And in some cases, as a parent, living in Appalachia below the poverty level, which I was when I was raising them, I had no way to enforce federal law that would protect them. There was no way. And so there were some really problematic situations for them, and even something as simple as having to buy bus tickets for my sons to get to and from school in the city where they lived, which we know, according to IDEA, it's their right to be able to be transported to and from school. But there was nothing I could do to protect my sons. And so that's a concern of mine, ongoing. I think how we as parents can really advocate for our children and make public policy count. And I will say that my sons have an older sister who found our situation so compelling. She is graduating from Vanderbilt Law School on scholarship and is going to be an attorney for those with disabilities, that's for disability rights. And she, so I can say the single mom, our efforts weren't wasted because she will be working in D.C. on Capitol Hill. But, I mean, it was a big issue for us. And I reach out to every educator, pre-service educator whose life I touch, and let them know our story because it was hard. It was just really, really
Thank you for sharing that. I really appreciate the involvement from the crowd. And actually, I think ending with some perspective from a parent is a really nice transition into our next activity, which will be the parent panel. And so we're going to transition into getting that set up for you all. You're welcome to go outside and speak with some of the vendors at this point, and then we will get that set up for everyone.
Probably want to thank them.
Are we leaving?
Yeah. Here.
Thank you. Do you have one too? Oh, did you?
Linda and Jay, can you hear me?
Just,
Can you hear me?
yeah.
Okay, now I can hear you. It's Angela. We haven't officially met in person, but I wanted to thank you for being on the panel today. And stay tuned because as panelists, I'll be picking your brains some more about how to write a policy brief and see if you would like to participate in doing that with us. So I will be in contact with you. Is that okay?
Yeah, it's hard to hear. Yes.
Can you hear me?
Email. Yeah, that's me. It's hard to hear anybody.
Okay. All right. Thank you.
Okay.
Thank you.
Bye.
Okay. Thank you. Thanks, Dennis.